Breast cancer is an extremely common disease. There is an increasing risk with increasing age. About 1 out of 8 women or so, by the time they reach their 60s, will be diagnosed with a breast cancer. Ages above that, even more common. Imaging studies to evaluate for breast cancer have improved dramatically in the past 2 decades. Mammograms are more sensitive, and most hospitals have digital mammogram capability now, and that is even more detailed than the older mammogram technique. The radiation dose from mammograms is not really a major issue compared to the ability to locate very early stage malignancies. We find that ultrasound is very useful whenever the density of the breast tissue is increased. This would be very common in younger women, and some older women have very dense breast tissue, and the ultrasound becomes important. When there is an equivocal or questionable result from a mammogram and ultrasound, an MRI of the breast may be ordered. MRI is the same type of magnetic resonance imaging that is done for other parts of the body, but there is a very special technique and special equipment necessary to do this. When there is a suspicion of breast cancer on mammograms, ultrasound, or MRI of the breast, then women go for a biopsy. This can be performed in a number of ways. Sometimes, if there is a palpable mass, then the surgeon may simply insert a small needle into the mass to verify that it is a malignant growth rather than a cyst. When a biopsy of the breast is analyzed by the pathologist, there are quite a number of things that they want to look at to help us with better decision making about what to do next. The tissue from a breast biopsy is sent to the pathology lab, where the pathologist and the assistants in the lab process the material. The tissue is examined grossly. The pathologist describes what he sees as he dissects the tissue itself from the biopsy. Then he processes it in a special piece of equipment that freezes the tissue and slices it very thinly so that he can look at small portions of it under the microscope. Most of the time, the pathologist will attempt to get very good samples throughout the entire tumor or area of the suspected tumor. As the pathologist begins to look at this material under the microscope, then he establishes the particular cell type of malignancy if, in fact, he sees malignant cells. He also describes these cells in a very defined pattern, using words like well differentiated or poorly differentiated. Poorly differentiated means it's very unlike normal breast tissue when they look at it under the microscope. Well differentiated would mean it looks more like normal breast tissue. Well differentiated tumor cells would be orderly, forming something similar to a gland or duct, whereas poorly differentiated would be cells of different size in a disarray to help us to generalize about the pattern of behavior of that particular tumor. All of this information is then generated into a report that goes to the surgeon and the other specialists involved. This information is, of course, very important to your oncologist in order for us to make decisions about the best technique of treatment, the best way that we can go about getting rid of any residual cancer cells or treating the cells that are there at present. The tissue from breast cancer biopsies is generally submitted to special testing in the pathology lab called histopathologic testing to help us to know how aggressive the tumor may behave. It is a generalization as to how the tumor may spread, how it may invade other tissues, or how likely it may be to respond to certain treatments. The most prominent prognostic indicator for breast cancer after the type of tumor, the size of the tumor, and the presence or absence of involvement of the lymph nodes would be the estrogen receptor status. That is always the top of the list for the histopathologic prognostic indicators. Normal breast tissue has estrogen receptors, and so when we check for estrogen receptors on tumor tissue, we actually hope to find them present, because that means that the tumor tissue is more like the normal breast tissue. More like the normal breast tissue means that it will respond in a more predictable fashion. It'll respond to therapy in a more predictable fashion, and it will respond to anti-hormone therapy. One of the greatest tools we have against breast cancer is anti-hormone or hormonal modulation therapy. There are several drugs that can be utilized for hormonal modulation. There's the old standard drug, tamoxifen, and a whole array of new drugs. Another of the pathologic indicators would be the HER2/neu testing. This is really looking at a marker on the surface of the cell, a special antigen that is found on some tumor cells. We really have some advantage in not finding this. In other words, a more aggressive tumor is more likely to be positive for HER2. But on the other hand, when the HER2 markers are present, then there is an additional drug that can be used to fight the cancer. So that's not all bad. The breast is made of ductal tissue predominantly, with multiple areas of small lobules, or areas that are the ends of the ducts. I kind of picture it like a tree. The lobules are like the leaves. They're out at the ends of the ducts. If you look at a tree, you see the leaves, but there's actually more trunk and limb and stem in a tree than there is leaves. The leaves are small. In a breast, there's lobular tissue throughout the breast, but if you really could measure out how much there is of ductal tissue, or the tubes that arise to the surface and go out to the nipple, there's actually more total amount of ductal tissue. And ductal carcinoma is a little bit more common than lobular carcinoma. With regard to ductal carcinoma in situ, or intraductal carcinoma, cancer that has not spread outside the duct, this is considered stage 0 cancer when it is actually limited to completely inside the duct. The specimen has to be examined very carefully to assure that there is no spread outside the duct, and if there in fact is not, then there is virtually no risk of spread to the lymph nodes and to other tissues of the body. At some point, the breast cancer has the risk of breaking through the wall and then going into the supportive tissues surrounding the duct. Once it breaks through the duct, it has access to the lymphatic system and to the bloodstream, and the risk of spread to other areas, from lymph nodes to even other areas of the body, is certainly a possibility. When a ductal carcinoma in situ is discovered, the decision making on whether or not sentinel lymph node sampling needs to be done is based on the size and the aggression of the tumor cells that are involved. When an invasive breast cancer is discovered, nearly always sentinel lymph node sampling or a lymph node dissection is a necessity. It is relatively well known that the majority of the breast has lymphatic drainage to the axillary lymph node bed. Lymphatic drainage refers to how the fluids in between the cells of the breast get out of the breast and back into the circulation. Our entire body contains a lymphatic system. It goes from the tips of your fingers to every other bit of your body. If we did not have the lymphatic system, our body would swell. Most people have heard of lymphedema. Lymphedema occurs when the lymphatic channels have been disrupted to a particular area of the body. We don't see that very often anymore in breast cancer because the way that we examine the axillary nodes has changed dramatically. Prior to about 10 years ago, sentinel node sampling was purely experimental. It was tested first in breast cancer and melanomas. It has become standard in those two areas and is now used in some other types of malignancy also. In breast cancer, sentinel node sampling is done by injecting a colored dye, dye into the area of the tumor, or in some cases into the area around the nipple, along with a radioactive tracer. Generally both of these are used because what will occur then is the surgeon will examine the axillary nodes and will be able to determine which ones have been discolored by the dye and which ones have uptake of the radioactive tracer. A small radioactive detector, almost the size of a pin, is utilized to test and see if the node is radioactive. And if so, then that would be one of the sentinel nodes. Now, sentinel nodes are not necessarily the exact same location in each person. What we're looking for when we're looking for sentinel nodes is which node is the most likely to be the first node in the lineup of drainage of fluid from the tissue from that part of the breast or from the breast in general. In some cases, one node will be a predominant sentinel node. In most cases, 3 or 4 or sometimes even 5 or 6 nodes will show up as containing the dye or the radioactive tracer. These nodes are sampled. It has been proven that if these nodes do not contain malignancy, then it's very unlikely that the remainder of the lymph nodes in the area will, if the dye and the tracer were absorbed and transmitted well to the lymph nodes in question. If these do contain malignancy, then generally the surgeon will go ahead with what is called a completion axillary dissection, meaning they will check for other involved nodes, and this generally involves removing anywhere from 6 to 10 additional lymph nodes that are located in a fat pad along the nerve, artery, and vein that lead out to the arm. That's the reason that many women will experience a numbness in the posterior aspect of the arm after their axillary lymph node dissection. That numbness or tingling sensation often takes a long time to go away. In fact, sometimes it may not even go away. It may be that the person gets used to it and it becomes no longer an issue for them. Up until the mid-80s, nearly all breast cancers were removed by mastectomy. It has been determined for at least about 30 to 40 years now that for the majority of early stage breast cancers, women have a choice. They can choose a mastectomy, which was commonly the practice back 20 and 30 years ago, and that is a reasonable approach, but most of the time a lumpectomy or removal of the tumor, also in some places called a tylectomy or a partial mastectomy, that followed by radiation offers the same cure rate statistically in the vast majority of early stage breast cancer. There are specific circumstances that prevent us from doing conservation of the breast surgery, as this technique is called. If there is skin involvement, sometimes that is not recommendable. If the muscle of the chest wall is involved, it often is not recommendable. If the mass is extremely large, then it is not a good idea. But these are specific cases. Every case is different, and every case has to be analyzed in detail by your oncologist, your surgeon, and the others involved in your care. When a woman chooses lumpectomy and radiation as her treatment of choice for the breast cancer, it's rather important to the radiation oncologist that the margin of excision, that is where the knife cut, be clear of tumor cells. It's preferable that there be probably a 3 millimeter or more. We prefer as large a clear margin as possible because that does mean less risk of recurrence. It's not uncommon for a woman to have a lumpectomy and for the pathology report to come back saying close margin, maybe 1 millimeter, maybe less than 1 millimeter. This is a very close margin. What that says to us is there may very well be tumor cells left behind. Well, it is true that radiation therapy may completely clear all of those tumor cells. The radiation may sterilize that area. That's the term that we use for it sometimes, to sterilize the field. But the reality is, it is more likely to completely clear the tumor cells the fewer that there are. And so, if the margin is positive or very close, we know that there is a little increased risk of failure to clear all the tumor cells. Therefore, increased risk of recurrence of the tumor. That's why we always lean toward getting a completely clear margin, whether the disease is invasive breast cancer or ductal carcinoma in situ. When the pathology report comes back with close or positive margin, it is a common practice to have the patient return to the operating room for what we refer to as a re-excision. A re-excision is simply going back into the lumpectomy cavity, the space where the lump was. Another word for that is the tumor bed. And the surgeon then takes additional margin of tissue all around that cavity to assure complete removal of the tumor. Sometimes the surgeon goes back and takes these margins and we don't even find additional malignancy. Sometimes additional malignancy is found and completely removed. If the margin remains close, there are situations where women even have to return for additional surgery. Of all the areas of the body that we treat with radiation, the most easily tolerated by the patient is breast radiation. The side effects from radiation are limited to the area that we treat. So when we treat the breast, women don't have any further difficulty with hair loss. There's no effect on the immune system. The blood counts stay normal. There's no nausea. There's no damage to eyes, ears, nose, throat, heart, lungs. There was a time back in the old days of radiation therapy where some of the effect of radiation could damage heart muscle or lung tissue. Now that we know that this was a risk, ways have been developed that we can avoid that nearly altogether. Occasionally a small sliver of the lung will be in a radiation field, but for the most part this is negligible. Most women never know it, even if there is a half centimeter or a centimeter or so of lung tissue in the field. Many times we can completely avoid this, and there are special techniques of radiation that can reduce the dose even when we need to come more deeply into the chest, such as in cases where the tumor was larger or when the lymph nodes were positive. Radiation therapy to the breast is so well tolerated that about 95% of women that finish their breast radiation say, "Well, I don't know what all the fuss is about because this was not a problem. I went about my activities." The women that were working, they keep working. Women come and go to their treatment, go to work or go to their community activities, and generally don't even have any significant problems. Only a small percentage even feel fatigue from the treatment. The side effects from radiation therapy are slightly increased after chemotherapy, but this is only a small amount. Radiation therapy does give inflammation to the tissues of the skin, the breast, and a little bit perhaps even to the muscle under the breast, the pectoralis muscle. We have women that go through radiation that have a reddening of the skin. In fact, first a little pink, and then sometimes a little red, and then it usually turns tan. With good skin care, it's very rare to see skin breakage. We do see that in a small number of cases. It's a little bit more common with larger breast size, and if there is more moisture accumulation under the breast or more friction of clothing on the breast or of the arm against the side of the breast. Friction increases the wear and tear to the skin that's already inflamed by the radiation. And yes, occasionally there is skin breakage. That's why we stress good skin care throughout the radiation therapy. The vast majority of women that come through radiation treatment to the breast have virtually no difficulties and have only just some dryness of the skin upon completion of therapy, which slowly resolves over a 2 to 4 week span, sometimes stretched out to 6 or 8 weeks for more extreme cases. Occasionally there's some internal swelling, occasionally some tenderness internally in the breast. Usually this is not severe. Probably 1 or 2 out of 10 patients will have tenderness that's significant. They might say, when I roll over in bed, it bothers me. It will wake me up because it feels tender. It does happen, but that always goes away over time.